So good afternoon, everyone. Welcome to today's endocrinology grand rounds. So before I introduce the speaker, I have a few things to say. First, I want to congratulate Dr. Levinson for his award for excellence as a retiree serving. He has been a professor of biochemistry for 40 plus years here in Louisville, and has continued to be here. And in fact, he's one of the few people who is here in person every single time. Unless he's out of town, unless he's in Boston or someplace. So congratulations, Dr. Levinson, for coming. So before I introduce the speaker, I just wanted, just as a personal note, because over the last 20 years or so, we have had three speakers, including him, who presented on diabetes technology. And they were all from my institute, the Postgraduate Institute in Chandigarh. Dr. Satish Garg, Yogesh Kudwa, and of course, Viral Shah. And the reason I have this picture out here is that that department of endocrinology was started by Dr. G.K. Rastogi, a very well-known endocrinologist. He was the founder of the Endocrine Society of India, the first department of endocrinology in India, and fellowships and everything. And without him, I would not have done my endocrinology fellowship in India. So we are very thankful for him. And this was a picture taken a couple of years ago when one of the junior faculty from PGI came to Louisville, and with him, we went to Indra Rastogi, Dr. Rastogi's wife. She is also a physician, and so she is a very strong supporter of all endocrinologists, and particularly endocrinologists from PGI. So that's why we are very happy to have her here today to introduce us. I wanted to introduce our junior person from PGI to her. So now, as far as Dr. Shah is concerned, he's not here because he's from PGI. Well, that's part of the thing. But no, the thing, he is one of the leading people in the field of diabetes technology. He obtained his medical degree from Saurashtra University, got his MBBS and also his residency there. And then he went to PGI Chandigarh to do his DM in endocrinology. He was highly successful, and he came to the United States where he got special permission. He got a distinguished foreign physician license, so he didn't have to do any residency or fellowship. And he has been, his first 10 years he spent at the Barbara Davis Center for Diabetes in Denver, Colorado. And recently, about a year and a half ago, he moved to Indianapolis, Indiana. He has moved up the ranks from being an assistant professor and associate professor at Denver to now being a professor with tenure at IU. He's also the director of the Diabetes Research Center there. He has a number of awards to his credit, presented widely, both nationally and internationally. He has 2 R01 grants that he has, multiple grants from the Juvenile Diabetes Research Foundation, which is now called Breakthrough Type 1, and numerous other industry-sponsored and other clinical studies. So he's really an expert in this field. He has over 200 publications, peer-reviewed publications, and 15 book chapters. So we are very happy to have him here. And we are also glad that he is close by so that whenever we need any help, we can reach out to him. So Viral, take over.
Okay, yeah, sure. Meanwhile, I want to say thank you so much, Shri, for inviting me here. And I will tell you one thing is that when I was planning to move out of the Colorado, I did talk to him that what's the best place for me and what should I do. And so I did ask for him about his mentorship and advice for my next career. And so far, it has been turned out to be great. So thank you. I appreciate that. Um, so today, I was told to talk about like a very broad overview on technology for managing diabetes. So this is going to be a, oh, perfect. Thank you. This is going to be a very broad 30,000 feet overview because each technology, and I was talking to fellows that I think the technology field itself is becoming a subspecialized field where a lot of things are coming up and you have to keep updated yourself with everything, which is going to be a challenging for busy clinical practitioner, whether you are an endocrinologist or diabetologist. I think it's going to be a tough unless you keep up with that pace. So it's going to be a very brief, but I'm here. And if you have any questions about any kind of a technology, thank you. I'd be happy to take those questions and discuss more in depth about that. Here are my disclosures. I have no conflict of interest because I have a conflict with pretty much all companies that makes devices. And I do work with them. And I do feel like an academia industry partnership is necessary to advance the science. So I think I'm grateful to them to fund me on some of the ideas because it's going to be a CME program. And Kelly, I'm sorry, I forget that I saw that event code. I didn't put that in my slide. Okay, perfect. Thank you so much. And so these are brief three learning objectives for my today's presentation. Number one, I think I'm going to review, again, a very brief literature around the evidence supporting use of diabetes technology for optimizing diabetes care. Then briefly touch base on everything that's available in US market at this moment. And then a few clinical pearls or practical consideration if you think that's helpful to you in your clinic. So I will start with this slide that probably you may have seen hundreds of times because this was a very famous slide used again and again in a multiple either grants or presentation. The T1D exchange was actually a good idea that was started about between 2010 and 2012. And the idea was that this was funded by Hemsley Charitable Trust. And the idea is that hey, we don't know, number one, that how many people with type 1 diabetes in the United States are using X, Y, or Z. And what is that outcome look like? What is the care look like? And so this was just a cross-sectional survey of about 70 plus clinics across the United States. So different geographical locations, different clinics. Most of them, I would say, they are academic centers. It was started with the pediatric center, and then a lot of adult centers were kind of also brought in to make that population as generalizable as possible. And I think we learned a lot from T1D exchange. So 2010 to 12 was kind of like a beginning of the T1D exchange, the planning and everything. And then it kicked off after that part, and it continued to be managed by JEB Center, which is a kind of a coordinating center based off Tampa in Florida. So I feel like it contributed a lot. And one of this figure here was the first publication from a Kelly Miller suggesting that what's the A1C look like across the lifespan in people with type 1 diabetes from the T1D exchange. The slide that I have here is an updated version of that part. So again, recently in a 2020-22, the T1D Exchange Clinical Registry is now got a new name called T1D Exchange Quality Improvement Initiative because they cannot fund such a large project forever. So they gave a twist to that in a different way to reduce the cost of this program. So in a 2022, they compared the previous version of that A1C across the lifespan and the newer version. So you will see here that kind of a red graph and then turquoise kind of a color at the bottom. The first one, the red one, is the 2016, 2017, and this is a 21 and 22. And what it suggests is that we are doing much better than before, of course. the majority of the improvement in A1C is still in adult population, a less difference in actually pediatric population. So you can see that big bump. I'm going to use my cursor here. Oh, it's not coming there. Let me use the laser and see if I can. There we go. So this big bump here, you see that part. That's the toughest age to really manage type 1 diabetes. Hasn't changed a whole lot there, but here, after the age 30 years, I think we made a lot of improvement. But other side of the story is that despite you have all these things available now that you can call newer insulins, you want to call some faster acting insulins, all these diabetes technologies, only 26% of people with type 1 diabetes, even in a 2022, are able to meet an A1C of less than 7%. And I feel like we can do much better. This hasn't changed that a lot. So look at the 2016 to 2017, that number was about 21% and improved by about 5% to 26. Again, the population A1C dropped by about, point percent. So not looking great, I would say. Okay, there is a lot of room to improve. What about type 2 diabetes? It's the same story. It's not a different story. You can see that there's three different publications. This first two are published by the same group from Johns Hopkins, Liz Selvin and her group. Just telling the same story that how many people with type 2 diabetes are able to achieve an A1C of less than 7, which is a desirable glycemic targets to prevent microvascular complications in the long run. And it sounds like about 50%, the blue one is the less than 7. So it's about 50% of people. Very recent paper, and they use the enhanced database. So it's kind of like not again the entire type 2 population, but a very selective population. And the most recent one is even more depressing, in my opinion, because it's only 30%. Of those population had an A1C of less than 7%. The third study is the Canadian study. That's also a Canadian population-based study. So what they did is that they merged two registries that were existing in Canada and combined those people with type 1 and type 2 diabetes. And to me, very interesting part is that I want you to pay attention to this one. It's type 1 diabetes, and this one type 2 diabetes on insulin therapy. Okay. And look at the people, the black bar is those who had an A1C of less than 7%. Exactly same in people with type 1 diabetes on, of course, on insulin, and type 2 diabetes on insulin. So if you look at this study, then I think the people with type 1 diabetes and people with type 2 on insulin therapy are very similar. Their outcome looks pretty similar too, right? People without insulin therapy are now doing much, much better, and thanks to the GLP-1 analogs and SGLT2. And I think we should use pretty much in all people with type 2 diabetes early from a course so that we can keep the insulin a little bit further away in their course of type 2 management. But anyway, let's try to see, where is the problem and how can we fix that, right? That's how I look at that. And so the problem is, we all know that. I think one part of that problem is the inertia. And I don't want to just say that it's the inertia is just us. I want to say that the inertia is, and this is a beautiful, actually, collection of article in a diabetes spectrum. If you haven't read that, I would encourage to read, because it talks about the inertia coming from a different aspect of our healthcare system, being it in hospital, being it our complex healthcare structure, that includes the insurance, that we need to do so many prior authorizations and all these things to really get the people what they want or they need scientifically. And then clinical inertia, meaning by that we are not able to keep up and doing enough to really move the needle further, right? And this is a good highlight of clinical inertia that I think you all are aware about that part. Not going to go into the details, but this is a Cleveland Clinic retrospective database. And what they did is that they looked at in 2016, the entire year, that how many people had an A1C greater than 9% in their database. Okay. Just a simple one question. How many people, whether it's a type 1, so this is type 2, how many people with type 2 diabetes with A1C of more than 9%, regardless of their therapy, where they are seeing on those Cleveland location and those kind of things, whether it's a primary care endocrinologist or something else. And then if you have someone with the more than 9%, you're going to do something, right? And then they looked at what happened with those same individuals after 1 year. About 75% stayed there. Only 25% had a change in A1C by about 1% point. Now remember that 9 to 8% is not difficult. It's difficult is that if you want to reduce that further, 7.5 or below 7, that's where you need more the therapies and aggressiveness in management. But 75% of the people walking in our clinic with the same A1C over and over and again. And I think it's a time to do something about it. We all in our institutions have grand rounds, we have case conferences, right? And I'm sure that in your case conferences, you are discussing about the difficult Cushing's, difficult adrenal adenoma, different things. How many times you have discussed that I have a patient with A1C of more than 10%? And I saw that person 2 times, both the times had more than 10%. Can I do something different? No, because we assume that it's their responsibility. Yes, it is their responsibility, but I think we can contribute a little bit on thinking about that. How can we do things differently to change that? And another problem, I think, is that now this inertia, which is the clinical inertia, also contributed by the guidelines, and the guidelines are very slow to change, and that's why ADA standard of care now made a living documents. Anytime there is a big randomized control trial comes in, the standard of care updates automatically immediately. Okay, because if the guidelines takes forever to change, we don't change. Because we believe, or we kind of like take that guideline for our source to do really scientific evidence-based practice, right? So this is a guideline from an American Association of Clinical Endocrinology, ACE. It used to be an endocrinologist in the past. And this was all evidence-based, so don't take me wrong. At the time, there were no automated insulin delivery system available in the market. So these were the criteria to start somebody on insulin pump. And the criteria were that somebody should be motivated. Somebody should be doing those carb counting, 4-finger checks per day, should have a support, able to carry out all these things safely, blah, 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 right? And we have followed that for a long period of time, and we are still doing that. And I see that all the time that patients refer to me with an A1C of 10.1, and what they were told is that let's first improve your A1C and then we'll consider your pump, right? But if someone has an A1C of 10 for a long period of time, that person is not able to do what they're supposed to do. Let's admit that part, right? And so I think those criteria that I call it's a myth now, that what's an ideal candidate for insulin pump therapy? In my opinion, there are no ideal. Everybody, if they want to, should be getting that, unless that there is a big safety issue. So this kind of a criteria should not apply to current generation automated insulin delivery system. So next couple of, and I think I'm going to highlight the 4 points. How can you really make a change to really improve the diabetes care in our clinic? One is that, let's think about that. A1C is a great biomarker for diabetes complication. Remember that part. It's a great biomarker, very well validated, both UKPDS, DCCT, many other studies around the world. So we're not going to go away from A1C. But it's not a good marker to optimize the diabetes care in a patients that you are seeing in a clinic. And it's 2 different things, okay? So I would highly recommend all fellows and faculties is that just don't titrate things based on A1C alone. If they are not on a CGM, the first step is to get the CGM. Look at the overall picture rather than just the A1C, because there are many phases of A1C that it's difficult to really come up with a plan that could be good for that individual. My second point would be that start as early as possible. Okay, don't delay things. This is a proof here. So Colorado, when I joined that later of 2012 and then 2013, I became a faculty. We started this small pilot project at the time. And very interestingly, that I pitched that idea to Dexcom, and Dexcom was willing to fund that at the time. So we did a first pilot study and then full-fledged cohort study later on. And what we did is that we just did a simple one thing. If the CGM helps in people with type 1 diabetes, because by the time the JDRF CGM trial was published, showed an efficacy of CGM in people with type 1 diabetes, the Dexcom G4505 was available at the time. So a lot of things were already happening, right? The question was that why don't you start early if that works? But we didn't have evidence. So we just developed this kind of a pilot, and the first was the retrospective, and then we moved that as like a prospective. And what we did here is that we just looked up between 2013 and 16 that how many people with type 1 diabetes that came to our clinic. Now at the Barbara Davis Center in Colorado, they had a very unique system is that the people who are discharged from the hospital, they will come to the clinic on the same day at the time that they are discharged, so that it's a very kind of a closed ecosystem. So we had a very good idea about how many people are coming in and what we are doing. And then we looked at simply how many people who started with CGM within their first year of their type 1 diabetes diagnosis. Most people were started with the mean of about 3.5 months in this cohort. And then people during the same time who did not start with the CGM. Now consider that in a real life study, you have a lot of biases, right? That you are introducing that into the study because it could be insurance cost, socioeconomical status, perceived bias by clinician. They're going to start system on someone that they think is the best candidate, so many things. But again, we followed this cohort silently for 7 years. Okay, that's the longest so far that is published in the history of the CGM. And look at the blue line. The blue line are the people who are started with CGM early. Okay, the orange line are the people who did not initiate the CGM. I don't need to tell you what you see. It's a clear, right? But what is interesting is that this dashed blue line. And what is that? So 2016, when we analyzed this data first time, we went to Colorado Medicaid because Colorado Medicaid did not approve the CGM at the time. And about 20 to 25% of our population could not get it because they were on Medicaid. And number was higher on a pediatric side than the adult side. And they looked at the data and they said, yes, we'll approve that. So 2016, we got a bunch of like an approval from a Medicaid. So a lot of people who were not on a CGM got the CGM. So this is the line. That means that they did not start the CGM to begin with, but started later in their journey of type 1 diabetes. Okay. Now look at that. So if you think about the median of about 3 years, that's where they started with the CGM, followed for 7 years, that's a 4 years. The dashed line never met that blue line. Okay. So lot of publications, and I'm not going to go into the detail of that part, talks about the glycemic trajectories. And the glycemic trajectory sets within the first year or 2 years of your diabetes. So you may be in that good, you may want to call good category, bad category, you may want to call it A1C category, whatever you think, but you set into that kind of a trajectory and you stay that in trajectory. And I feel like if you help these people to have a good success to begin with, they will be into that trajectory of a success and they will do a really good job in the long run. The second hypothetical reason for this dashed line still not meeting that blue line is that, so in the first 3 years of data, there were more severe hypoglycemia and hospitalization in that orange line compared to the blue line. And you know that very well because you all practice medicine, is that once the patient has a severe hypoglycemia, majority of them is going to have a post-traumatic stress disorder, and it's called hypoglycemia fear. That fear is something that they will not try to keep their blood sugar on normal or lower side, right? They will try to keep it on higher side. So despite that you provide them a tool, I see a lot of patients, and I'm sure that you all see that too, is that they always eat something before going to bed. Because in the past, we used to call as a dead in bed syndrome. And those who are lived with type 1 diabetes for 30, 40, 50 years, They are the ones who are going to eat something before going to bed because they want to make sure that they are waking up tomorrow. That's a habit, right? And that they have done for 30 years. Do you think it's going to change? No. So this dashed blue line are the people who have an hypoglycemia fear, something else. It's going to take a longer time for these people to really come back, or probably they may not. So remember the point number 2, start it early. Number 3 is that this is not something that I think our healthcare would design to, but European systems are, and I will talk about those data soon. The universal access to AID. What I mean by that part is that anyone with type 1 diabetes in your clinic, and the data is strong for type 1 than type 2 because type 2 are just emerging. So I'm going to talk more about type 1 here. Regardless of their baseline A1C, regardless of anything, just ask them simple question. Have you thought about insulin pump? Yes. Are you interested? Yes. Let's go on. And if you do that part, you're going to change outcome. And that's what we did. So after 2013 success, that 2016, we published that CGM data, and then we followed that another 4 years. In 2021, we looked at that, how did we do in last 10 years by this project, right? We started CGM early. And when we started the CGM early, the people also got interested in getting pump too. And so the use of CGM and pump was continuously going up. So now you see here that the use of CGM 2014, 15, 16 was about close to between 30 to 40%. 2016, and that's where the Medtronic 670G introduced into the market, right? And then you got tandem control IQ somewhere between 2020 to 2021. So look at the device uptake, the blue line. So 2021, right now it's almost close to 90%. When I left, it was almost more than 90%. But with that part, look at the entire clinic A1C. I'm not talking about 1%, 2%, 3%. I'm talking about the entire clinic. Okay, and that was a 7.5. And so you can see that here, 2016, 17 did not change much, but the later on it did. That was a contribution of an AID. So more AID use led to a more drop in clinic A1C. Now that's just the one clinic. What about rest of the world? And so this is an international registry comparisons, okay? And then what you see here in this yellow one is the different registries. I'm not going to go into the details part, and I will talk about that when I show you the graphs. The T1D exchange is the one that I described to you earlier. So you are probably familiar with that now. So what you see here is that the proportion of people achieving an A1C of less than 7% across those different registries. Okay, one simple metric. And then you see here that it sounds like these 4 colors, the green, blue, red, and yellow, are doing something better than other 3 here, right? So what's something that they are doing that we are not doing? And that's how the intention is comparing and learning from each other, okay? So these registries are Norwegian, Swedish registry, Denmark, and Czech Republic. Okay, so these 4 countries had almost 50% of those type 1 people with A1C of less than 7%. Now they analyzed all the data, and what they figured out is that these are the countries that have a universal access to technology. So if you look at the Sweden, 90% of people have a free access, okay, because they have a centralized healthcare system. It's a different than us, right? It's a big contributor to doing well, overall improving the diabetes care in a clinic. And then the one that are not doing well are United States, Australia, and UK. And they do not have universal access to technologies. And the technology uptake is much, much lower. US is now catching up much better than actually Australia, and UK has now their own NHS quality improvement project where they made the CGM access universal. So hopefully that will change in the future too. So my colleague actually Khan wrote a really good editorial in Diabetes Care and saying that I think in US I hope that all the insurance and healthcare would probably come up with something close to an universal access for AIDs in people with type 1 diabetes. What about type 2 diabetes? So type 2 on insulin, I think, we all know that the CGM evidences are enough to say that level A, meaning by that evidence coming from a large randomized controlled trial. So we should use that. AID, we have two trials published, the Omnipod 5 called Secure T2D trial. I will talk about that in a second, and Tandem Control IQ Plus. Tandem Control IQ Plus is slightly different than Tandem Control IQ. So if your patients, you see that in a clinic, and if they are using only Tandem Control IQ, tell them to upgrade that, because there are some additional features that they will benefit from. And it's a pretty simple to update that pump. Type 2 not on insulin therapy, it's a level B. And why level B? Because I think type 2 diabetes not on insulin is pretty heterogeneous disease. Someone is just on a metformin plus GLP plus SGLT2. Someone is taking probably even more than that, right? So it's a pretty heterogeneous disease, and depending on what kind of population is being recruited in a clinical trial, the outcomes or the results are very different. But there are strong real-world evidence that suggests that the CGM in type 2 diabetes, regardless of the insulin therapy, really improves the outcomes. And the outcomes that are looked into the real-world registries are hard outcome, meaning by that the hospitalization due to anything related to diabetes. Probably going to skip that part here. But the interesting is that this is one of this real-life study. And to me, it was so interesting. I looked at this paper probably multiple times. If you look at here, no medication change, net zero medication change, meaning by that they try to change, adding a 1, taking out another 1, that's a 0. Medication added and the medication removed or reduced, right? Regardless of those categories, the CGM group had lower A1C. And if you look at the MOBILE data, MOBILE was the randomized controlled trial. People with type 2 diabetes on basal insulin therapy randomized to receive a real-time CGM, that was a Dexcom G6, and a standard of care, which is SMBG. There was almost a 0.4% reduction in the A1C, adjusted A1C, in CGM group compared to the SMBG group. And now if you look into the supplementary table of that publication, it was published in JAMA, no change in insulin dose between two groups. Identical, that means that physician didn't change anything. And the drop in A1C, that means it's purely due to a behavioral change made by the patients during that trial. So secure T2D, because these are something relatively new, so just wanted to touch base on that part. And I think I had a conversations with fellow that I think the biggest thing I feel is that we should avoid is that looking at people with type 2 diabetes on insulin and type 1 differently. Okay, they are very similar because they don't have enough beta cells, and that's why they are requiring insulin, with some differences in pathophysiology and insulin resistance, many other things. But they would benefit as someone with type 1 in terms of technologies. So this was not, I would say, 2-arm randomized control trial, but this was a single arm. So everybody on type 2 diabetes in Secure T2D, type 2 diabetes age 18 and above, and less than 73 or 74, using insulin therapy. Now they had 3 arms within that: only basal, twice a day NPH, or 3 times a day, that's a multiple daily injection. They recruited pretty much everybody less than 10% A1C, even someone with the 6.5, but the 6 and 6.5, those kind of categories were restricted to less than 10% or so. And what they saw is that, and then after 2 weeks of that standard therapy, everybody got the Omnipod 5 for 3 months, okay? And what they saw is that very remarkable improvement in A1C. So baseline A1C was 8.2, end of the treatment was 7.4, okay? And very interestingly, let me ask you this question. If you start an AID in someone with type 2 diabetes with the A1C of 8.4 and now drop to an A1C of 7.5 or 7.4, what do you think? System is giving more insulin or less insulin? More effective. It's being more effective. So if you look at the total daily dose, there was a 20% lower total daily dose on Omnipod 5 compared to the baseline, right? Why? And I think it's a very simple. a lot of people, particularly in a basal insulin group, what do? We tell them to do a fasting plasma glucose if they do. If not, we just look at the A1C and we just keep increasing the basal insulin. That leads to two problems. Over basalization, number one. Number two, a lot of people are not taking it. And so if it's coming as a high A1C, you are just increasing by another 5 units. When you put an AID, it just gives you that, right? So the actual insulin that you're supposed to take on paper versus actual insulin that you need is very different. I hope that makes sense. And also the insulin pump therapy, the insulin reduction insulin dose requirement is generally 5 to 10% lower than multiple daily injections. This is Control IQ Plus. Very similar. So mean baseline A1C, again, 8.2 in this. Sounds like they have trial design in a very similar way. But this was a 2-arm randomized control trial, meaning by that one arm was the Control IQ Plus. The second one was the standard of care, meaning by that whatever the group that they came in, whether it's a basal or the multiple daily injections, they just stayed on it. And then look at the time in range difference. It starts within the first week. Okay, you see that blue and the red one, and this is a week number 1. And if you try to dissect that week by every day, the blue versus red are different on a day 1. This is exactly what all type 1 trials have showed too. Okay, so I think this is we have a really great trial now coming up in a type 2 that hopefully will open up a space that we should probably start looking at those type 2 diabetes on insulin therapy and coming up to us with an A1C of 8 or 9. I think those people would do much, much better on AID system. That's what the guideline says too, by the way, right? So guidelines are currently anyone with type 1 diabetes, CGM AID is a standard of care, level A evidence, type 2 on insulin, CGM level A evidence, and then not on insulin therapy is currently level B for CGM. AID, the recommendations will change because now we have those 2 trials. So hopefully that will change to level A because both were randomized controlled trial. Okay, so now I'm going to switch a gear and talk a little bit about what systems or what devices are available in the market right now. So CGM, you know this very well. So I'm going to probably skip that quickly. You have got Dexcom, you've got 2 generations still available, G6, G7. G7 is now going to be approved for 15 days rather than just 10 days. So it's coming soon. Probably they are planning to release that by the second or third quarter of 2025. So hopefully you will see that, but it's exactly the same Dexcom G7. So there is no difference in a form factor, just the sensor life will be different. You got Libre, you got Libre 2, 2 plus, 3, 3 plus. Plus means it's a connection with pump. Otherwise, it's the same. So science is same. It's just that the designation for pump connection. The Eversense, I think I got a lot of questions from fellow about what I think about Eversense. And I gave them my opinion that I think all the devices are becoming to a point now that they are very similar to each other. They are like cars. Each one of us have a different cars, but they do pretty similar job is take you from one place to another place. Okay. But the interior exteriors are slightly different. And someone may like red color, blue color, orange color, whatever that color you like, gray color, or some kind of an interior with a stick, no stick, it's your choice. In all CGM and AID space, they pretty much do very similar job. There are some minor differences that I feel like I wouldn't care much as long as the patient is willing to try. And the finances and the cost, right? Because our healthcare system is slightly different where if insurance doesn't approve, then it's costly. The Eversense, they have a program, $99 program, and it's a 1-year sensor. So people who cannot afford Dexcom or Libre, I think it's a good one. You can talk to your rep or someone, but you do require someone to do insertion and removal. So that's a downside. Then you got a Simplera standalone CGM that is not being used widely in a market, but it's an option. And now Simplera got approved for 780G as well. So by second quarter, they're going to have a lot of marketing in ADA because they are trying to launch at ADA Simplera with 780G. So hopefully all our patients that are not liking that Guardian 4 Connect, we all hear that problem, right? All the time. hopefully they might like the simpler slightly more than and they also announced the partnership with the Abbott, so that's another thing. I'm not a big fan of connected pen, but that's something an option, and I think I do believe in options, giving those options to patients and let them decide. But in pen is available for Humalog, Novolog. It's only for rapid-acting insulin. Remember that part, not for long-acting insulin. What I don't like about those different connected pens are a couple of things. Number one is that it doesn't provide you any dosing decisions or guidance. Number one. Number two is that, like an in pen, it's only for short-acting insulin, right? And then people don't enter that long-acting. So when you look at the basal bolus, it's not accurate data. It's not integrating with the EMR. Patient has to email you or fax you, and then your clinic has to provide you a kind of like, there is no like centralized portal. So I think there are a lot of factors that are still not provider and patients friendly, I call it. It's not friendly to us because it requires a lot of work, and not friendly to patients because of a lot of work that they have to do manually, and nobody would like to do manual at this moment. Bigfoot Unity is currently not available because acquired by Abbott, and then don't know the future, but it sounds like Abbott has some plans, so we'll see what comes out. And Lilly Tempo. Lilly has less interest right now, so probably no one comes to you and talk about Tempo because they are focused more on GLP right now. But Lilly used to have a diabetes technology division. They ran it for 4 years and trashed the entire division because they got hit by GLP. So I wish that it stayed, but it did not. There are a couple other options available. These are online. I never use them actually, but you can look up. They are approved by the FDA, 510K approval, and their website says it's a $25. But my incline is generally either CGM going to the AID rather than that intermediate pen, but it's an option. This is a beautiful article. If you want to read about that part, Diana Isaacs from Cleveland, I think, wrote when I was a guest editor on endocrine connections. And this one actually briefs all connected pens that are available in the US market as well as the European market. And then pros and cons and everything. It's a nice tables with all the information that probably if you would like. Simplified pump options. I just wanted to give you like all things available in the market. Not a big fan, again, for various reasons. The Vigo is still available. It's now by Mankind that manufactures the Afrezza, that's an inhaled insulin, available in 20, 30, 40 units. So 20, 30, 40 is based on the number of, so the basal unit that is provided by the pump itself. So 20 divided by 24, 30 divided by 24, and then 40 divided by 24. So I think it's a 1.7 unit or so. So it's a constant one basal rate. You cannot change those things, which is fine. And then you click it, and then each click gives you 2 units of insulin. So it's trying to simplify that kind of a pump option, right? Secure Simplicity is only for bolusing, so it doesn't have a basal rate. It's approved now. It used to be only for 3 days, and now they extended up to 5 days because it holds about 180 units of insulin. So people who don't require a lot of insulin, it can last up to 5 days now. And the Omnipod Go, so Omnipod had a plan in the past that they wanted to have multiple product portfolios for type 2 and type 1. But then when we did a secure T2D trial, they saw a success, and I think they decided to not worry about Omnipod Go. So it's not available in the US. It's still available in certain European countries. That was designed for a type 2 diabetes, just giving you one constant basal rate. Again, trying to simplify that pump option, but it's not in the US market at this moment. So here are the AIDs, and I think the 3 of you at the end already took that picture because this is what you want to remember, as simple as possible. I think don't try to complicate things. One basal rate, that's what matters. Don't try to have multiple basal rates. It should be a safe basal rate. Focus on the things in your clinic that matters the most in terms of improving the AID performance. Like, for example, on Omnipod 5 Medtronic, the basal rate doesn't matter. So don't even look at that, right? Only thing, 2 things that you want to look at Medtronic is the AIT of 2, target of 100. If you have that part, nothing you can do. So even though if you're not happy with the system, probably changing here and there minor things is not going to change a lot, okay? The twist is coming up. It's already got a 510K. For a pump, they are partnering with the loop. And I think someone did mention from a fellow that some people are using those DIY loop. This is exactly that DIY loop that was channeled into the Tide Pool, which is a nonprofit organization started by people with type 1 diabetes to commercialize that loop. So they created a channel for commercialization that was already available in a DIY community. It's a lot more complicated than our traditional AID. So I think it would be good once it's available. I would suggest that probably because it has so many different settings. Remember, the DIY communities were very like engineering community, right? They had like so many things. So everything matters in a twist. Your basal rate, your correction, your safe glucose limits, your insulin code. They have 3 different types of food options. Depending on which one you click, your insulin profile will be different. So let's say lollipop, pizza, and tacos. There are 3 options. If you click lollipop, that means it's a fast-acting carbohydrates. So your insulin curve will be like giving you too much of insulin upfront, and then within, stopping that within 1.5 hours. If you have a tacos or pizza, then it's more extended. So it's very kind of an involving kind of a things. There are 2 things. It's called correction limits and then the safe basal limit. Safe glucose limit. So that's for suspension. That's for the target. Again, I think we will learn more once they provide us more detail. Now, if you put everybody on AID, not everybody is going to still have an A1C of less than 7%. Remember that part. Because current generation AIDs are not something to develop to keep the A1C around 6. Okay, they are designed just for safety part. So if you have someone with an A1C of 9, they will bring it down to 7.58, but they're not going to lower that to 6.5. Those things require a lot of tweaking, and people will do that part. One of the way to do that part is the bihormonal pump system, right? So one is the insulin glucagon combination. People have tried Simlin. Simlin probably doesn't have that. Sorry, pramlintide, I should say. That's a scientific name. Then Simlin is the brand name. Doesn't have much future because I think the companies doesn't have that portfolio to take that further. So I don't know what's going to happen. But the glucagon is a potential that hopefully will come out in future. There are a couple of questions that needs to be answered before FDA will convinced with that. And the questions raised by the FDAs are that how much glucagon that your body produces per day and how much is pump is giving you. If the pump gives you more glucagon than what you required, then what are the consequences of that part? What's going to happen to the hepatic, the glycogen storage if you are continuously pumping glucagon? So those questions, I think, but it's easy to, and there are also about more mechanical questions on the stability of the glucagon, the degeneration of the glucagon within the cartridges, that, the infusion set and those kind of things, the fluctuation in temperature, pressure. But hopefully it sounds like people have worked that for many years and figured out a lot of answers to those questions. So hopefully, I don't see that next year, but probably down the road, that's a strong contender for bihormonal system. One, I personally think that is coming probably sooner than other is that not within the pump itself, but as an adjunct therapy would be a GLP-1 analog. So we're going to present this trial at the ADA. You're welcome to, if you are coming to Chicago in June, please attend that. It will be on June 23rd at 3 p.m. All hot clinical trials are presented at the ADA on the last day because they want people to stay the last day. It never works. I give them all the time feedback, but still they keep it at the last day. So it's on Monday. But this was the first double-blind randomized control trial, placebo-controlled trial. So 72 people, its last patient last visit was in August. Data has been analyzed. So I think hopefully this trial will give a signal to the industry to really move forward. The another one is that the Lilly has already announced that they are doing a tirzepatide in type 1 diabetes trial. So that would be for FDA approval. They have a 2 trial, dose finding trial, and then the efficacy trial. And so things are coming. And if that gets approved, we will see that in a type 1 space. My point number 4, the last and probably my practical advice, if possible, is that take some time, think it through. but try to spend more time upfront so that you don't have to spend time later on in your clinic. And what I mean by that, so when I moved to the IU, I spent about 3 months to really come up with all these different pieces of puzzle and put together to develop what I call it's an integrated diabetes care model. And after 3 months, now I feel like I'm getting payback after about a year now, because it has made clinics so efficient and really good. What I do and what I developed over time is that I didn't ask the hospital for anything that cost them, because hospital are not going to provide you any resources that going to cost them money, right? So I just asked for the resources that are already available and then tied them together. Okay, so what I did is that for my clinic, I do a Tuesday morning and Thursday morning, which will change to only Tuesday moving forward. But those 2 days, I have a diabetes educator with me. The diabetes educator will be literally on the same day. So what I have my patient, let's say, scheduled at 8 o'clock in the morning. I have a 30 minutes of window. I see the patient. I take care of all the medical stuff that I need to do. But remember that most of our patients with type 1 on a pump have a lot of questions: infusion set, prescription, this, that, right? And that's not a lot of science. It's a lot of practicality of using that part, or exercise and this and that. Oh, I do this, it doesn't work, right? I have my diabetes educator seeing that patient on the same day after my appointment immediately for 1 hour. So the patient gets a 1.5 hour a quality of that conversation, and they are happy, we are happy. That changes a lot, because that education makes them to really or encourage them to really do more. And also, after these are seen, we have a certain criteria that if we are starting a new GLP-1 analogs, insulin therapy, someone has an A1C of more than 9% for a while, people that are not showing up multiple times, no shows in clinic is pretty much everywhere. It's about 30%, between 20 to 30%. It's a problem for us, right? Because you lose the revenue for that. So we are moving that and referring them to the pharmacist, and the pharmacist cannot bill on the same day that physician see, but you already have a 1.5 hour of a quality time with the patient. That patient will be followed with the pharmacist every 2 to 4 weeks, depending on what they're doing. If it's insulin pump insulin titration about 2 weeks approximately. If it's a GLP-1 titration, it's a 4 week, because you change the dose every 4 weeks, right? They also take care of blood pressure, lipid, making sure that things are good, vaccination. And then by the time I see the patients in a 3 months, it's fixed most of the time. Okay, and we have also set up a channel where it's an industry academia partnership. So pretty much anyone that walks into my clinic, we talk about the pump and CGM. As soon as they decide, from a decision to getting that pump trained is 2 weeks of time. That's our goal. Am I doing that? No, but it's our goal, and it's working out so far good. And this is the data actually. So this is a pharmacist data. So you can see that about 30% of the patients were referred to the pharmacist for diabetes per se from endocrinologist. And then you can see those visits. Average A1C reduction by pharmacists treated people with diabetes is about 2%. But remember that part, it's because that we are also referring them with someone who is not showing up in a clinic, having high A1C. But when the pharmacist talks to them every 2 to 4 weeks, it's a little nudge, and also developing that personal relationship with that patient, right? You can still see that the fill rate is about 60%, meaning by that the 40% of those people still do not show up at that time. But our intention is that out of 4 visits, even though if they can make 1 or 2 visits with a pharmacist, it will develop that relationship and make those changes, And 60% fill rate is a good enough for us to really have the pharmacist salary really paid through those income. So summarizing my talk, I would just say that summarize those my 4 points. Don't rely on A1C alone. Start technologies as early as possible. CGM and AID, both type 1. Strong evidence type 2, a lot of coming up, and then try to spend time with your leadership and see if you can develop that kind of an integrated model, developing some efficiency around your clinic to help your people to optimize the outcome. With that, I will end my presentation. And if you are really interested on learning every single things about technology, it's a 2 days of a very intensive boot camp. You can scan this QR code. will require registration. It was on August 21, 22nd, but it's all hands-on. So no theoretical talks, but how this pump, you have to insert the sensor, take out the sensor, download that, how to interpret that report. So it's going to be a pretty kind of a boot camp, like 2 days of workshop for diabetes technology. Thank you so much for your patience listening, and happy to take any questions if you have. I think I may have gone over a little bit of a time here, but it's in IU, so in Indianapolis. So NCAA is the NCAA headquarters. That's a beautiful place, and we just booked that for this workshop. Yeah, of course. I don't know how many people are on Zoom, but yeah. Yeah, sure. Because I don't see anything on a chat that pops up here. So. Oh, now I see something in a chat. Okay. Oh, that's a CME code.
Yeah. So no question there.
Dr. Michiganum, it's Kelly. I didn't see any questions in the chat.
Okay. Yeah, I looked at it. So,
yeah.
The question, how many, in terms of resources, okay? I don't know how it is in Indianapolis, but we have a general shortage of diabetes educators. So, because still, for the number of people with diabetes, we do have a bit of an issue in terms of getting people who are claiming that able to claim for the field.
Yeah, no, it's true everywhere, right? And that's true even in IU, in Indiana University. And so a hospital was not willing to like, okay, that I'm going to give you this one, right? But the idea was that all these diabetes educators are seeing patients anyway, right? Why don't you just spare that? So I think I tried to convince is that I'm not going to let their revenue lose, my revenue lose, but why can't we just make everything it like a timed? It does require a lot of coordination because then scheduling people, right? You want to inform them part. You want to also schedule your schedule in a way that, because our clinics, I heard that here the clinics are at 15 minutes. At IU, it's a 30 minutes for me, but the educators are 1 hour. So if you have 4 patients in 1 hour, educators cannot see all 4 patients, right? So you have to also time that part. So it does require a little bit of like a workup upfront. But I do personally think that it's doable as long as the leadership is willing to really invest in that part. Again, they don't have to invest the money; they have to just reorient the things that are already available. So after I doing that part, I would just say that I started with n equal to 1, right? So they were willing because they're like, oh, just a little requirement. Now I'm doing for second endocrinologist. So Thursday we are making now second day for diabetes, and they're now willing to provide another one because now the data, right? That's and the people who are not showing up are now coming to pharmacists more often. So I think they are seeing that change and they are willing to. So my division has now said that, yeah, we have a second one that we're gonna probably pull that from other IU health resource. I think we can expand that a little bit. And we are also hiring the second pharmacist too. So yeah.
So question that was sent by, so one of the things they asked was, what is the time that the pump needs to learn the algorithm? How quickly, on a day-to-day basis, can it adjust, or does it require more than?
Right. That's a great question, and I will repeat that for Teams or Zoom people here. Is that how long a certain technology or pump takes to learn or optimize the insulin delivery? And I would just say that none of the pump learns anything actually, except that certain parameters that optimize the insulin delivery, right? And so it's a pure mathematics. If it's A equal to B equal to C equal to D, then they're going to just make those kind of an equation work. each system, let's say, for example, Medtronic requires a 48 hours of no AID to collect the total daily dose before you can start the automated mode because it's a TDD-based insulin delivery. Same thing on Omnipod 5. So Omnipod 5, the first port is not going to be perfect because it takes your basal, multiply by 2 as a total daily dose. But then the insulin delivery for those 3 days of that port, 72 hours, will be collected as a TDD for a next port, and the average get better when you have it more than 3 ports, right? So for Omnipod, it takes about 2 to 3 ports. Tandem, 1 day, because it takes the same basal rate, right? iLet, same day. So I think the technologies are pretty good, the current one, but so I would highly recommend that people who are started on technology, they should receive a call on day 3 because that's a first infusion site change and something other things, then 1 week and 2 weeks, because most frustrations comes during that first 2 to 3 weeks. And if they are not being supported during that time, a lot of people are gonna just don't like it. So if you develop that part, and I use actually industry source for that part, where they make sure that they call that, they support them part. After that, most people will do. It's pretty automated.
So the other question that how does the pump manage to take into account physical activity, those kinds of things? Is that part, could it be automated?
The answer is yes. So there are a lot of studies have already been done and already patented by each of this company, I would say. It's just a matter of implementation based on various factors. Like one of the example is that hand movement. So either your wristwatch, something else, they can use the hand movement to surrogate that for your food. And pretty damn good data that even though if you do fact 5 times, it's not going to count you as you're eating food. It looks at like literally rhythmic movement for a certain period of time and learns that pattern recognition. It's a pattern recognition from you. So that's one way of detecting food. The another one way of detecting food is this rate of a change in a glucose. And then that's what the Medtronic does, meal detection, right? Rate of a change in a glucose. And if it's exceeding certain or something, then its assumption is that there is a food, but no bolus. Picture of the food, that's another technology. So I would say there are multiple already existing off-label in the market where you just take the picture of your food, it analyzes that and tells you exactly that it's a 30 grams of carb, and you can literally put that in your pump if you want to do that automatic. So combining that part through an AI is also possible. In a future, one of the CGM is going to have that feature coming as well, where you just use the CGM, take the picture, and it will completely take that data and suggest you over time. Now, in terms of the exercise, that's more complicated than meal detection. So I don't think that the exercise space is going to be enthusiastically like jumped on by industry first. I think the meal detection is going to come first. Exercise is going to be tough because of a lot of variables that are involved in that. You can detect the exercise, but then what to do in terms of the insulin, that's a tricky part. And so one of the discussion in scientific community is always that it will be easier for engineers when the fast-acting insulin will come into the market. And I'm not talking about so-called fast-acting right now that are available. These are like a really an ultra fast-acting insulin, because in that case, it's easier to manipulate the insulin delivery. And I do have two kind of questions on a chat. One is about CGM in pre-diabetes. Currently, I would say that we do not have any scientific evidence to use that part. But if patient wants to use that part, yes, of course, I would use that, because it just, you learn something from it. You learn from different food, exercise, and something. And if that motivates that individual to stay healthy, sure. And I don't think that there will be any randomized control trial. Remember that part, from pre-diabetes to type 2 diabetes, it takes 10 years plus or even more. Nobody's going to do that kind of a clinical trial to prove that CGM is going to prevent the progression from pre-diabetes to type 2 diabetes. But I feel like overall, it has become more of like a lifestyle thing. Like, for example, your Fitbit, Apple Watch, it doesn't require an FDA approval, but you use that data to really try to be healthy. So I hope that answers your question. Will exploiting this technology at the pre-diabetes stage can help, similar to CGM monitoring? Okay, so there are 3 questions within that part. I would just say that in pre-diabetes, probably most people are not on any medication or maybe just the metformin in some instances. So other than CGM, I don't think that any other technologies would be helpful. Continuous insulin monitors would be a great tool for research, but I'm a little bit skeptical about the clinical implication. What are we going to tell about our patients if the insulin is high or low? What I'm going to do, right? So I think the clinical implication will be limited, but the research-wise, yes, it would be good. And Dr. Kulkarni, I think Kulkami, you have your hand raised, so I don't know. Do I need to unmute you, or you can unmute yourself and ask question? Okay, the hands have been down now, so
Okay,
yeah.
maybe he
Okay.
was the one.
Yes, that's true. Okay.
Okay, thank you.
All right. Thank you so much, everybody. Thanks for having me here.